thank the College of Surgeons for the opportunity to present at this year's Clinical Congress. On behalf of the CODA Collaborative and my co-moderator, Dr. Gianna Davidson, we are describing the long-term results of the CODA trial. The conflicts of interest below have been reported by co-investigators. The CODA Collaborative itself represents 25 hospitals across the United States. Long list of site investigators, including co-principal investigators from the fields of surgery and emergency medicine. Appendicitis has long been treated with an appendectomy, but multiple randomized trials in Europe have demonstrated that selected patients can benefit from antibiotics instead of an appendectomy. These trials were limited because surgeons determined who was approached. They did not include people with perforation or an appendicolith. And in fact, the perforation rate in the surgical arm of the largest European trial was less than 2%, which is considerably less than the average rate expected in the population at large. There are also differences in typical practice in the trials in Europe versus US practice, and there has been little uptake of antibiotics in the United States as a result. One of the reasons to offer a new trial of antibiotics versus appendectomy is that patients have a keen interest in understanding if there's a non-surgical option. Surgeons strongly need evidence about what works more effectively in subpopulations, and occasionally the healthcare system is rocked by a pandemic that requires us to think about triage and who should have access to the operating room. The CODA trial was asking the question, are antibiotics as effective as appendectomy for appendicitis, and used a general health status measure, the EQ-5D, at 30 days as the outcome. Other clinical outcomes, safety outcomes, and time in healthcare were measured as well. We specifically were focusing on which patients might do better with one treatment or the other, and we looked at patients with appendicolith, these had been excluded from prior trials, and they represent 1 in 4 patients with appendicitis. This was a pragmatic trial, taking advantage of the way care is delivered in the United States and reflects normal treatment patterns in the United States. The population of patients included 1,552 randomized patients. They had CT evidence of appendicitis, and patients with perforation or appendicolith were allowed into the trial. We excluded those with abscess or free air, diffuse peritonitis or septic shock, pregnancy, or those with severe phlegmon, or where both treatments were contraindicated. Antibiotics were delivered intravenously for 24 hours and then pills for 10 days. Patients could be hospitalized or discharged from the emergency department after receiving IV antibiotics, and many were discharged after 1 dose of long-acting intravenous antibiotics. We recommended appendectomy for patients who worsened, and in the appendectomy arm, laparoscopic or open procedures were allowed. This was an intention to treat analysis, and we looked at the appendicolith subgroup as a separate analysis. This was a non-inferiority trial, and while we looked at other outcomes using traditional statistical approaches, it was in the antibiotics group that we looked at Kaplan-Meier estimates over time to determine the rate of appendectomy. The data analysis was frozen at 1 year, and so some patients have up to 4 years of follow-up, but almost all patients had access to the 1-year follow-up point. Results of the trial were reported last year at the Clinical Congress and demonstrated that antibiotics were non-inferior to appendectomy based on the EQ-5D at 30 days. We did not see a difference in safety events, but complications were higher in the antibiotic group, driven by those with an appendicolith. The appendectomy rate in the patients having antibiotics at 90 days was 29% overall, 41% in those with an appendicolith, and 25% in those without an appendicolith. A set of other outcomes, including time missed from work and resolution of symptoms, varied between the antibiotics and the surgery group and were either equal, favored one, or favored the other treatment option. The American College of Surgeons incorporated these findings into their triage guidelines for emergency general surgery and recommended that antibiotics are an acceptable first-line treatment. Today, we're going to be discussing the long-term outcomes of the CODA trial. We have 3 presenters. The first is Dr. Lillian Cao, a professor of surgery at University of Texas, Houston, and the site PI at UT Health. The second speaker is Dr. Callie Thompson, an assistant professor of surgery at the University of Utah, who was the site PI at Vanderbilt University. She'll be discussing personalized medicine aspects of the CODA results. And lastly, my co-moderator, Dr. Gianna Davidson, an associate professor of surgery at the University of Washington, and the director of CODA's Clinical Coordinating Center, will be speaking about how to pull all of this information together to help inform your daily practice. We look forward to the speakers and then the discussion that follows. Thank you for your attention.